Hi, and welcome to Kaleidos Medically Speaking. Each month, we'll explore a variety of topics to help you better understand certain medical conditions and treatment options. My guest today is Dr. Aaron Hoffman, the Chief of Surgery at Kaleidos Health. Today, we'll be discussing reflux disease and some of the latest advancements in treatment. I'm Mike Hughes, and this is Medically Speaking. Welcome, Dr. Hoffman. Thanks for joining us today.
Good morning, Michael.
I know we want to talk about reflux disease. Can you explain the condition and what's happening in the body with reflux?
It's not uncommon after a greasy, fatty, or spicy meal for people to have a little bit of heartburn that passes in 10 or 15 minutes. Some people may even take a Tums. That's natural. There's always some element of heartburn if you eat something that might not agree with you. When patients come to see me regarding GERD or gastroesophageal reflux disease, many times they will suffer from anemia from blood loss from ulcers in their esophagus. Sometimes they'll wake up choking on food, and otherwise some of them may be prescribed antacid pills from their doctor or from their gastroenterologist.
Sure. So tell us a little bit more about the risk factors of having reflux and how that can impact a patient.
The two largest, most impactful risk factors of having reflux are, number one, obesity. When patients are overweight and their abdominal girth gets larger, that increases abdominal pressure and can cause reflux. The second most common finding for patients with reflux would be a hiatal hernia. That is, some stomach has crept up out of the abdominal cavity and starts poking its nose up into the chest, and the valve becomes ineffective. Gotcha. Other patients, we're not sure why they have reflux, but we can see it on testing studies that, in fact, their symptoms are due to reflux. That is, some acidic juices from the stomach going up into the esophagus where they don't belong.
How are these types of ailments treated? Is it prescribed medications? Is there invasive surgeries?
For the majority of patients, 95% of patients, just one pill a day can take care of their symptoms. And for the majority of patients in consultation with their doctor or gastroenterologist, the pills are so strong nowadays that it can keep the symptoms at bay. However, some patients don't have complete relief on the pills, and other patients just don't want to take a pill every day.
So there's been some headlines in the news recently about, the pill a day or some of the side effects some patients may be experiencing. It's causing a little bit of buzz in your world, so talk a little bit more about that issue and what patients should be doing about it.
There's two major groups of patients that come seek help from me for their reflux. One of them is patients who do not have complete relief on the pills. That is, they take a pill a day, maybe two or even three they're up to, and they do not have complete relief. Many of them seek out help because they're sick of the reflux or sometimes food coming up in the back of their throat. The other group of patients are ones that are motivated to get off the pills, and there has been some attention in the news lately that taking one of these seemingly harmless pills a day can potentially cause health problems, everything from Alzheimer's to kidney failure. The data is pretty weak, but the media sometimes can really scare people. Sure. And many patients that I see are very motivated to get off that pill.
Sure. So you've been performing surgeries at the Buffalo General Medical Center. Buffalo is a spicy food, a fast food, a greasy food type town. Talk a little bit more about the procedures you're doing. What are you doing to help combat reflux?
Traditionally, repairing the hiatal hernia, that is laparoscopically with the cameras, bringing the stomach back down in the abdominal cavity where it is, with sometimes a wrap of the stomach, that is creation of a new valve to prevent the acid coming up, was the tried and true gold standard operation. About 6 years ago, there was a new device that was brought into the United States called the LINX, L-I-N-X, LINX device. And some of our viewers can read about it, but it essentially will augment or help that valve perform more naturally and through a 1-hour procedure at Buffalo General in combination with fixing the hiatal hernia. We've successfully implanted the LINX device, and all of the patients that we've implanted have come off their antacid medications.
Is that an outpatient procedure, inpatient procedure? What's the typical stay for a patient?
Although the procedure is done laparoscopically with cameras with minimal pain and smaller incisions, we always keep the patients overnight just for safety, and they usually go home the next morning. It requires an overnight stay. 5 years after a traditional hiatal hernia repair in Nissen, studies have shown that about 63% of the patients would do the procedure again. With the LINX procedure, about 95% of the patients 5 years later would say they would do it again because they don't have some issues with bloating that can sometimes happen with the traditional surgery.
So the success rate is directly related to the technology.
Yes, it's more physiologic. Sometimes with the traditional operations that have been around for many, many years, patients find it frustrating that they can't burp, or if they have the flu, they can't vomit. With the LINX, they're able to eat and drink normally, and also bring up a burp when nature calls, or every couple of years if they have a flu, they can vomit. So they don't get those bloating symptoms like the traditional surgery.
How do you determine who's a candidate for this type of procedure? Is this something where the patients are searching the web and they find you, or they referred in by primary care docs, their GI specialists? How do you determine who's a candidate, and how do they find you?
Patients come to us several ways. Sometimes it's a happy patient that tells all their family and friends, oh, what a great job we did. But the most common referral would be patients searching out a more appropriate treatment for their reflux that no one's discussed with them. They find links on the web. And then, of course, a large number of gastroenterologists are familiar with the most up-to-date literature, and they refer the patients from the GI unit. Many times, patients will call us and ask what kind of workup is involved. It usually starts with an upper scope to make sure that is an endoscopy to see the stomach and the health of the esophagus, to make sure there's nothing more serious going on causing their symptoms. And then we have to prove before we can place the links that they have reflux and that we can help them.
Patients who may be suffering for this, they're in pain, they're in discomfort, when they hear things like, we have to scope you, or they hear things like hiatal hernia that has to be pulled back down, that can be intimidating for patients. What can you tell patients who may be intimidated or afraid of coming into a hospital setting to have something like reflux treated, which maybe they had thought it should just be through medication? How can you eliminate that stereotype?
So for 90 to 95% of patients, a pill is all you need. And if you have complete relief, that's fine. However, many patients who have incomplete relief or are motivated to get off the pill because of the safety concerns of the medications, they are usually very, very motivated to have these operations done. I will tell you that because of the technology that Kaleida provides us at Buffalo General, and because of our track record of being the pioneers in these new kind of surgeries in Buffalo, the patients really have nothing to worry about.
Gotcha. So patients who may be, future patients who may be watching this, or may refer people over to Buffalo General or calling your office, what advice do you have for them? What steps should they be taking? How do they go about getting treated for this?
The first step for most patients is to ask their family doctor for a referral to their gastroenterologist to have this worked up. If they feel as if they hit a dead end or they're not getting the answers that they want, they could always contact us at the Center for Minimally Invasive Surgery at Buffalo General, and we would help work up the reflux-like symptoms. Of course, sometimes heart disease, heart attacks can also mimic chest pain or discomfort. So it's important that they seek immediate medical care if this is a sudden finding. In reflux, this is usually a chronic problem that happens over many years. I would just like to make sure your viewers that don't, especially if they have sudden chest pain and ascribe it to reflux and taking a Tums, that there's always a chance it could be a deeper issue. So make sure that you see your doctor right away if this is something that suddenly has happened.
Sure. Dr. Hoffman, thanks for joining us here today.
Thank you, Michael.
Appreciate it. Thanks again for joining us today. I'm Mike Hughes. We'll see you next time on Medically Speaking.